Good evening, ladies and gentlemen. Welcome to the IMPA's regular monthly medical update education program. Before we start, let us rise for the national anthem. Thank you. Thank you. Actually, this is our medical update program that we have regularly. I would like to thank the sponsors of this evening, the USV company of Sri Lanka, is headed by Mr. Zawahid, who volunteered to sponsor tonight's meeting. But unfortunately, due to the corona situation, we had to restrict our audience to just 30 participants, physical participants, but also we are going hybrid. We are online to anybody who wants to join the program through Zoom, thanks to our expertise there at the back of the room. Now, before I continue further, I would like to introduce our guest lecturer who has taken all the trouble to come all the way from Gaul to make a presentation. Normally we have a presentation of 2 lectures, but today I restricted to 1 because people are reluctant of the corona situation. So this is Dr. Susit Amarasinghe, who's come to the electrocardiophysiologist and a cardiologist also. He has a MD MRCP from London, and he's going to speak to us on the topic, the key concepts in the management of critical care in arrhythmias. So actually, Dr. his biodata is here in a short form. Cardiologist and electrocardiophysiologist at Karapiti Teaching Hospital in Gaul. And he has had many presentations and research papers. If I go through it, take the entire evening. So I will now call upon Dr. to make a small presentation. Before we start on that, I would like to give a small opportunity to our sponsors to promote their products. Thank you. Thank you. Now I call upon Dr. Amar Singh to make his presentation.
Good evening, everybody. Thank you very much, Honorable President, and for the kind invitation. And I would like to thank the IMPA as well as the organizers and the industry support for this event. And I thought to discuss. It's a great privilege and honor for me to be here. And I probably know some of you, but with the mask I can't recognize. Kindly excuse me for not talking to each one of you. And I thought to make use of this time to discuss few key concepts in managing cardiac rhythm abnormalities that that will hugely help day-to-day patient that you're all taking care of, to the extent that some of you may be able to save lives by picking even small or even minor looking ECG abnormalities and having a high degree of suspicion. I will base my talk on few case scenarios, which are real cases that we have encountered over last 3 to 4 years in my center in Teaching Hospital Karapiti. Just to give you the background, I was appointed to Teaching Hospital Karapiti in 2016 as the first cardiac electrophysiologist. And at the time that I took over, there was no electrophysiology services in Teaching Hospital Karapiti or anywhere in down south or beyond. And today we have a very busy unit where we see one of the busiest EP centers in Sri Lanka, and we see almost 500 to 600 new patients every weekly or so. it has become very busy, meaning that there are so many rhythm abnormalities. There are so many rhythm problems which are always associated with general medical problems that we see day-to-day life, in day-to-day life, including diabetes, hypertension, ischemic heart disease. All these are very closely related to rhythm abnormalities. So you will see how it becomes relevant. I'm sure you all know, I'm sure you all are familiar with this, but it's always nice to refresh your memories, maybe to pick up few things that we talk about these days more than in the past. In the interest of time, I'll proceed with my talk. And no conflicts of interest. Right. Thanks. Okay, so there's now talking about rhythm abnormalities without refreshing our memory on the basic anatomy and physiology. Cardiac rhythm is the result of a very complex as well as very efficient electrical system that coordinate the anatomical components of the heart. So let's discuss about these the few concepts that I plan to discuss in the form of few cases. So this is the first case I selected. This is an 8-year-old girl. This is about 8-year-old girl who had congenital hearing impairment and who was on multiple anti-epileptics for recurrent seizures. She was referred to us from a peripheral hospital in down south. The reason was that she was on multiple anti-epileptics, still continued to get seizures. And we thought to look at her cardiac status. And the first thing, of course, naturally we do would be a ECG, and this is what the ECG showed. And it may not be very clear, but if you can see any striking abnormalities, or does it look normal or abnormal? Very often, even an ECG with significant abnormality might look very normal, because that's the ECG. The problem with ECG is very complex. Unless you look in a methodical way and unless you analyze each of the components as well as the patterns, it's a bit difficult to sometimes pick things. So here, there's a striking abnormality of the QT interval. If you see from the QRS complex to the T wave, it takes about 3 large squares. So a rule of thumb here would be, if your T peak of the T wave, if it falls beyond the half of the RR interval, beyond half of the RR interval, then we are talking about QT prolongation. So this child had congenital QT prolongation, and the seizures she was getting are actually not true neurological seizures. They were polymorphic ventricular tachycardias, what is called Torsard's TT pointers, the VT, polymorphic VT. She has, when she goes into the VT, the cerebral perfusion drops. Therefore, the brain starts having epileptic seizures. That's why she didn't respond to the medication. And once we pick this up, we actually manage her with beta blockers. This is her. We have got the consent to show her face. Eventually, because this is a lethal condition, this is a particularly rare syndrome, which is called Jawel-Lange-Nielsen syndrome or JLN syndrome. We had to implant her on this device, intracardiac device, to save her life. She's doing very well. Now she's 14 years, much taller than this, and she's doing very well. So she was one of our first few patients, and it's a success. In fact, she became the youngest patient in Sri Lanka to have this type of a device, which is called implantable cardioverter defibrillator. So that this particular device can detect any significant cardiac arrhythmia with a electrical shock, like we give in a manual defibrillator. So the device is very sophisticated and it can pick all the rhythm abnormalities. So we had to implant this under general anesthesia. She's doing very well. can you move the slide, please? Because it seems to be, okay, thanks. So this is again a similar case, a 42-year-old male, very striking presentation actually, history of nocturnal. He was complaining of difficult in breathing in the night. So he was suddenly getting up a feeling of drowning sensation. So he goes to sleep without any problem. Suddenly in the middle of the night, he wakes up feeling that he's drowning or he's finding it difficult to breathe. And this is the only significant symptom he was initially complaining of. And when we actually talked to him retrospectively after this particular episode, in addition, he was having mild faintishness in time to time, fainting episodes, not full-blown loss of consciousness, time to time. So once he was brought to the hospital, that's when we first saw him, and he was brought in a collapsed state. And subsequently, the family managed to trace a CCTV footage of this event because he was a cashier working in a hardware store. And they traced the CCTV footage and showed to us. And it showed a proper collapse with seizure movements and a lot of factors pointing to a cardiac syncopal episode. And when we, obviously, by that time we knew the diagnosis, we did the ECG and a few other basic investigation. And the ECG, it looks quite normal except for one striking abnormality. The abnormality here we see are, so this is sinus rhythm, normal rhythm normal, satisfactory rate. So you don't have any ischemic changes either. Only problem is this. So if you look at V1, V2, V3, this V1 there's a ST elevation pattern with a down sloping ST segment. Down sloping ST segment. This is a classic syndrome which is called Brugada syndrome, which is due to a problem with sodium channels in the cardiac myocytes. So that's a sodium channelopathy. This is very common in Sri Lanka, in fact, unfortunately. And not everyone has the lethal form, but we need to subject them to a comprehensive risk stratification to identify who's at high risk. So just taking a simple ECG, we can identify who's needing more assessment. So it's one thing. So few facts about few things to remember about this particular problem. If you see this V1, V2, V3 ST elevation pattern, not a horizontal pattern that you see in ischemic or ST elevation MI, like it's a down sloping ST elevation. And this can become very pronounced during a febrile illness. If someone who's having this channelopathy has a fever, they're going to have more pronounced features, as well as that's when they going to develop VF, VT. So the few advices we give to them, one is avoid fever. Whatever the reason they get fever, they have to start taking paracetamol early, control fever. That itself might save their lives. And they need to present to the hospital, be under monitoring. In case if they go into the arrhythmic episode, which is a VT or VF storm that they get. This is a one captured event of him. And we did the telemetry Holter monitoring while he was in the hospital, and we managed to pick this episode. So this is the problem. If it happens at home, and if it goes on beyond few seconds, he's going to die. So that's the other problem. So eventually he also needed a device implantation, which we did in teaching hospital Karapete, and he's doing very well at the moment. So the point there is, again, the ECG, subtle changes, but sometimes might give you a very important information. Case 3. So a few other cases, I will try to go through them quickly. 49-year-old male, executive of a private company, very typical story. Risk factors, type 2 diabetes, GORD, somewhat high BMI. He has been having occasional unspecific chest pains. Suddenly collapsed at his office. He was an executive. He collapsed one day in the middle of the day. Unfortunately, so he has collapsed. Unfortunately, there was nobody to give any first aid or chest compression, CPR, cardiopulmonary resuscitation. By the time he was brought to the emergency unit, he had fixed dilated pupil. So this is a very classic history of someone who's developing acute MI, collapsing, dying due to arrhythmia. So people who just die with MI, they died because there's an arrhythmia associated with the cardiac myocardial infarction. So only thing that could have changed his situation. Obviously, there are a few things that could have changed his situation if he identified his risk factors, if he was careful, if he took medical attention, maybe this could have been prevented. But the last thing we missed was there was no one who could identify what's going on and just give simple chest compressions, not even breathe, rescue breathing. If you just continue to give manual compressions, that's more than that. Sometimes that may be just enough to save his life, because what we need is some perfusion, maintenance of some perfusion of the vital organs till he's brought to the hospital. So, unfortunate story. Again, something similar. A 17-year-old boy was very well. Actually, he was almost an athlete, trained athlete. Retrospectively, the only symptom the parents were able to come up with was some pre-syncopal symptoms of faintishness that he had been occasionally complaining of. So when we say faints in a child, then naturally we think of simple faint or vasovagal syncope. We should never do that. It can be a lethal error until we subject the person into a basic assessment. We should never conclude. There are occasions when the history is very suggestive. It's a classic vasovagal syncope. That may be a safer situation where you can conclude that. But however, we should not stop there. At least doing a basic ECG will not lose much. ECG being one of the very useful investigations, cardiac-wise, at a minimum cost that we can do these days, which can give a lot of information. So this child, unfortunately, again, no bystander CPR, he passed away, and the postmortem examination revealed myocardial thickening. We know what it is. It's a hypertrophic cardiomyopathy. Again, the problem is till most of these arrhythmic syndrome, the problem is till they come up with the index event, sometimes they don't have significant symptoms. The only event they might get is a cardiac arrest. And if they are in the wrong place at that time, unfortunate for them. So this 69-year-old male, previous STEMI 5 years ago, who has been on, so STEMI, whenever we talk about a STEMI patient who has had a ST elevation MI, we should know that they are at high risk of sudden death due to arrhythmia. MI, myocardial infarction, almost synonymous with ongoing arrhythmia risk. So it's that related because the infarcted area is very arrhythmogenic. The infarcted myocardial areas have multiple electrical circuits, re-entrant circuits, which can trigger ventricular ectopics, which can trigger R1T ectopics, which can trigger sustained arrhythmias. So that's the problem with myocardial infarctions. And so this was a person who had a STEMI and who was known to have low ejection fraction of 35. Again, a very high risk factor. If you see someone who has a low ejection fraction, that also means they have not only that they have heart failure, problems with that all the problems that come up with heart failure, they also have a very high risk of sudden death. Sudden death meaning they die of a cardiac arrhythmia without pre-warning suddenly. The low ejection fraction is one easy factor that we can identify to select them for closer supervision. So again, this person has had pre-syncopal faintish symptoms and unfortunately was found dead in sleep. So what could we have prevented it? Definitely we could have prevented it. What he needed was a proper adjustment of his medications, optimization of beta blockers. If he still had high risk, if we identified him to still have high risk by way of rhythm monitoring, like Holter monitoring, if we picked up any significant or high risk features, we could have offered him a device therapy, which is actually one of the last options we give. But before that, there are so many things we can do. We can optimize his medications. We can keep him on optimum antiarrhythmics, see how much of improvement we see in his rhythm abnormalities. Next slide, please. So the entity or the concept I want to convey here is the entity of sudden cardiac death. It is not synonymous with heart attack or myocardial infarction, you all know. Sudden death means sudden arrhythmic death. And most of the deaths that are associated with myocardial infarctions or heart failure or other cardiac pathologies, significant pathologies, are related to sudden death due to arrhythmias. So much so that it is one of the most leading causes of death. But unfortunately, we don't talk about it because it's not easy to comprehend, because we don't see the arrhythmia often. By the time patient comes to us, either he will tell patient might say that I had faintishness or syncopal episode or palpitations. If he's lucky to come to us to tell the story, that would be the symptom. If he's not lucky to come, then he's dead. So that's where the problem, the challenge with these arrhythmia problems. That's why we need to have a high degree of suspicion. So a lot of people who suddenly die in the community, which happens every day, which is called out of hospital cardiac arrest. If they had proper assessment, most of them could have been prevented. In Western countries, there are so many things that they do, to the extent having defibrillators in the community level, which are called automated external defibrillators, to prevent this type of deaths. So we are not yet there. We are trying to see whether how to improve the situation, at least, of course, by improving the awareness and getting our public to know, or the relatives of, or each family members to know the importance of giving chest compressions in a situation of a collapse. You don't lose anything, you will save the life. So few definitions, I don't think we need to go into details. So sudden cardiac death means sudden and unexpected death occurring within an hour of symptom onset. It's not a death that goes, it's not the death following symptoms that goes on for hours and hours. Patient is very well till patient develop some significant symptom like faintishness and collapses. So these are not, of course, uncommon, not uncommon in Sri Lanka, not uncommon worldwide. And the categories of people we see are not all of those who have ongoing medical problems. And most of them are much fitter than us, actually, much fitter than us, very healthy, professional athletes. That just, you see in the news how they die during competitive sport. So very often they have an underlying arrhythmic condition which has not been picked up before, and on a given day, some degree of exertion, some degree of, when it goes beyond the threshold of developing the arrhythmia, it will trigger the arrhythmia, which causes a cardiac arrest. So unfortunately, even in Sri Lanka, we had this experience, which is very sad. And we might not be able to prevent everything, but definitely having a high degree of suspicion, listening to their symptoms and identifying or picking up what are more important, what are significant, we can certainly pick up some of these patients and save them. So epidemiology, as I mentioned, it's not uncommon. So sudden cardiac death accounts for 15% of all deaths and 50% of cardiac related deaths. The problem in Sri Lanka and Asian countries is we don't have the data, statistics, especially we don't have data on community. What was the circumstance of death most of the time. So that's where the problem, that we should not take it as the reason why we should ignore this entity. So that would be a concept that we should have in our mind. So the commonest causes are coronary heart disease, cardiomyopathies, inherited arrhythmia syndromes, and valvular heart disease. What you can remember is anybody with a structurally abnormal heart, has a higher risk of arrhythmic problem. In addition, even trivial problems like diastolic dysfunction, uncontrolled hypertension, they all can increase the risk of arrhythmias by a certain degree. I wouldn't say it's a cause for sudden death, but they all can contribute or can be cumulative in the process. So if you analyze the reasons or the arrhythmic episode that leads to the cardiac arrest, so most of the time it's a ventricular arrhythmia. If it's a VF, it's a very sudden death. If it's a VT, it can go, the patient might develop the symptoms, can last for some time. That's when we have the chance of giving chest compressions and bringing the patient to the hospital. Likewise, that would be the biggest percentage. And then we have the bradycardias, including high-risk bradycardias like complete heart blocks, advanced degrees of AV blocks, likewise. Next slide, please. So again, identifying high-risk patients, like people who have had a MI in the past. If it's a recent MI, again high risk. So it has a bimodal risk pattern where immediately after MI, for the first few weeks, there's a high risk of arrhythmic incidence. And then if they survive that period, generally it become a bit better. And later on, if they start developing myocardial scar, and then again it increases the risk of arrhythmias. Of course, as we mentioned, the heart failure and other underlying cardiac structural abnormalities. Having said that, there are arrhythmic syndromes that are there in structurally normal hearts as well, like the syndromes that we saw, like Brugada syndrome, long QT syndrome. They come in patients who have structurally normal heart, whereas scar-related ventricular tachycardia, MI-related ventricular tachycardia, VF, they are all in structural abnormal hearts. So we need to look at the patient profile and see. So ejection fraction is one of the very useful ways of predicting someone's risk of sudden death or arrhythmic death in a patient who has previous myocardial infarction or heart failure. So we discuss about this. Next slide, please. Yeah, so both tachyarrhythmia and bradyarrhythmia both can be similar. So what is the way to prevent it? Of course, the CPR. Not even, of course, advanced CPR. The basic life support will save their life till they recover. So there's this concept of sudden cardiac arrest, chain of survival. So it's an important concept to remember. So chain of survival, early access, early chest compressions, early defibrillation, early advanced care. So these are the key points in saving a life of a patient who just collapsed. So what we need to take is, of course, early defibrillation in Sri Lanka would happen only in a hospital setup, but in other countries it is available in the community areas. Fast chest compressions, by educating the public, that is very much a feasible thing to do. So this is a graph that I would like to discuss, because this shows how dramatic the decline of success rates for every minute that passes by, how badly the success rate decline or their survival rates decline. So that's why time is a life here. So every minute is important to save their life. So if there's a delay in starting resuscitation, then their chance of survival in the long term is less. If someone has immediate chest compression started after a collapse, they have a very high success rate of surviving. So that's a point I like to highlight. So this algorithm where we generally use to identify these patients who are at risk, and then make decisions on managing their risk of sudden death. That is for those who have symptoms, who are lucky to present to hospitals for further assessment. Next slide, please. So the next concept I like to convey is the syncope. So it's almost similar. What we need to understand is, this is a very common thing, syncope. So people collapse or faint. Not everyone is having a lethal arrhythmia, but we need to understand some of them. A certain percentage of them may be having something very significant. Next slide, please. So there's a standard classification of these syncopal episodes. So very commonest is actually what is called vasovagal or neurocardiogenic syncope. It could be situational. It could be secondary to something like orthostatic hypotension or carotid sinus syndrome, where imbalance in the physiological mechanisms playing up to cause loss of consciousness. Next slide, please. So it could be due to other transient or reversible causes like volume depletion, maybe certain drugs that we give to the patient that causes postural drops. So all these we have to look at before we conclude what's the reason for loss of consciousness. Next slide, please. However, we should not forget this entity of arrhythmias that we mentioned. So if someone comes with these symptoms, and if you need to, there's no harm in doing a basic ECG, asking a few basic questions that exclude or suggest cardiac symptoms, and look at any other important basic investigations. Next slide, please. So there are mimics. So there are conditions that can mimic LOC, transient LOC, or syncopal episode. Next slide, please. So pathophysiology, as I mentioned, is generally related to imbalance in the physiological mechanisms, either exaggeration of the vagal mechanism or combination of few things like vasodilation or bradycardia likewise. Next slide, please. So I'll quickly go through a few other interesting cases, which again we manage in down south, and where we were able to cure patients of life-threatening problems. So this is a patient who, this is actually a priest who presented with very significant shortness of breath, palpitations, who could not actually, which was affecting his day-to-day activities, and also a couple of episodes of loss of consciousness. And the ECG was this, and you can see it doesn't look normal, and I'm sure you will pick up what it is. It's a very famous condition, which is called WPW syndrome, where you see there's no, the PR interval is very short in him. PR interval is short, and you see that the slur of shock or delta wave between the P and the QRS. So P wave continues with a slurring. So if you see this, some of them may be having a very, very significant problem or almost a fatal problem, where this can trigger very dangerous ventricular arrhythmia due to this accessory pathway. So this was an episode that he developed, where during our assessment, where we took him to the cardiac cath lab to look at his properties of his accessory pathway. We electrically stimulate the heart to identify how it behaves, and it triggered this. So it was very clear, and he had typical symptoms during this time. So we managed to, next slide, please. So this is how we place catheters inside the heart to identify, and then do the mapping to identify electrical activity inside the heart, and then identify where it's unnecessary abnormal connection. Next slide, please. So this is when we have done this is during tachycardia that we have induced, and we look at the pattern of electrical signals activation to identify where is this culprit electrical circuit. So we got rid of it. If you see carefully, so here you see the delta wave, and then it's not there. So this is when we have done the ablation. So we deliver heat and get rid of the circuit. That's where his circuit was, inside the heart, in the left atrium, between left atrium and left ventricle in the mitral annulus. So it was, these are very fulfilling procedures, because you see then and there patient getting cured of a life-threatening problem, and of course a very debilitating problem as well. So again, this is a classic history again, 62-year-old male, history of anterior STEMI some time back. We know. The point I want to make here is someone who has a significant event like a STEMI, coming with any significant cardiac symptom like recurrent pains or palpitations, loss of consciousness, until proven otherwise, it's an arrhythmia. So here we see a broad complex tachycardia. The term we use here is, we won't just conclude that it's a ventricular tachycardia. We just say it's a broad complex tachycardia. That's a very safe way of approaching this type of people. When we say it's a broad complex tachycardia, what we mean is the QRS complex is broad. It's beyond 120 milliseconds, so beyond 3 small squares. We know in physiologically, normal QRS complex is within 3 milliseconds, 3 small squares, so 120 milliseconds. This one is much wider than that, meaning that it is arising from the ventricle, not through the normal conduction system. Therefore, it has a wider QRS. So that meaning that he has a ventricular tachycardia. So this needs to be sorted. We had to optimize his medications. Likewise, something again similar. In this patient, this was a patient who has a previous MI, who came with very high heart rate with almost very low blood pressure. Here the difference is he has relatively wider QRS. She has this anterior Q waves and a slightly wider QRS complex. During tachycardia, it's not that wide if you look at carefully. So it's a SVT actually, but coming on a patient who has a compromised heart. The patient, there's no cardiac reserve. So whether it's a VT or SVT doesn't make a big difference if the patient has a compromised heart. That's the point I want to convey. So we don't diagnose patients' condition just looking at ECG. To the extent that sometimes the ECG only give you some idea, but you have to look at the patient, look at the factors, and then we know the patient has high risk. Even a SVT in this situation can cause a cardiac arrest. That's what we need to understand. So SVT meaning supraventricular tachycardia, which is arising from the, which is either due to a classical re-entry circuit or atrial origin one. I think we can skip the next one. The next one, please. So these are somewhat similar. This is a very interesting one. I thought in the interest of time, I just mentioned again. Back, please. Okay, so previous history of MI, we see this narrow complex tachycardia. Next slide, please. So the QRS is very narrow, very narrow. So it has to be SVT, generally speaking. But in his case, actually, it was a VT. What happened was this particular tachycardia was coming from the scar area where it was behaving like part of the normal conduction system. So it was using part of the normal conduction system for this VT to propagate when we study. Next, please. Okay, so in this situation, we can't wait with medications. We have to deliver electrical therapy to get rid of the tachycardia. Next slide, please. Next, please. So eventually, how we improve this type of people is we can implant a device that can improve their LV functions, left ventricle ejection fraction, which eventually will improve their reduce their risk of sudden death, as well as improve their quality of life and the exertional capacity and the cardiac reserve. Next, please. So one of the last cases I want to share, last few. Sorry, back please. Yeah. So this is actually one of a very recent patient we had, a very unfortunate case, where a patient was just referred to us to my clinic week before last, and the patient, we found this ECG on her, and she was fine, but because she had this high risk, she had this rhythm. I'm sure you will understand. There are no organized P activity here. She has QRS complexes, but no proper P waves. So this is atrial fibrillation without very fast ventricular rates. However, she has no proper electrical activity, organized activity in the atrium. So this is atrial fibrillation, very common condition. The problem was, so we decided to admit her to optimize her medication. Before even we finished the clinic, we got the message that she has had a stroke. She has had a stroke. So she was having a left atrial thrombus already by the time she was referred to us. Obviously, no one can know unless we look for it. So unfortunately, she had that, but she was in a way lucky because she had the stroke, developed the stroke while in the hospital. So we managed to thrombolize her then and there. She recovered quite significantly. Almost 90% of her weakness improved. She was very lucky in a way that she had it when she was in the hospital. Next slide, please. So the point is, atrial fibrillation is again almost a lethal condition. We used to think it's just low on atrial fibrillation, nothing to worry, but it's not anymore. It's a very bad condition. It can cause debilitating strokes. It can cause life-threatening conditions. So therefore, we have to be careful with these patients. If someone has atrial fibrillation, irregular pulse, we should not stop there. We have to look at their risk. If the patient is beyond 65 years, or if the patient has hypertension, diabetes, or any other cardiac risk factors, that means their risk of forming a thrombus is very high. So these people, it's mandatory to have anticoagulation in the form of warfarin or one of the new agents. As you are aware, now there are newer agents which can replace warfarin. Now, the point is, in the past, we used to look at patients and see who need warfarin. And most of them, we thought they don't need anticoagulation. Warfarin is a very messy drug to give. But now it's completely other way around. We have to carefully look to see who doesn't need. Majority will need warfarin, anticoagulation, to prevent that type of debilitating strokes. So that's a concept I like to convey there. So if look for risk of strokes. Of course, you have to always look at the bleeding risk, but generally, so we have a tendency to say if someone has a risk of fall, so if someone has a little marginal low platelet count, okay, they are high risk of bleeding. It's actually not true, and we should not do that. Even however high the bleeding risk, their stroke risk may be higher because these risk factors are generally common to both sides. So until we are very convinced, it's always better to keep them on anticoagulation with careful monitoring. But of course, if someone has a previous ICH or if very AV malformations, or if there are other real risks, that's a different story. But if just for perceived risk, we should not deny them of anticoagulation because invariably they are going to develop a stroke at some point, which can be prevented. That's a important thing. Next slide, please. So the concept is there's what is called ABC approach to management of AF. A means anticoagulation, so to avoid stroke. B means better symptom control. You don't really need to cardiovert them to sinus rhythm all the time. That concept is no more. We can either aim for rhythm control or rate control. rhythm control is preferred in a lot of patients, but if it is difficult, it's okay, as long as we keep them on anticoagulation. Then managing comorbidities, because AF is very closely related to other comorbidities like hypertension, diabetes. So if someone has AF, management of AF also means managing hypertension properly, keeping them on proper antihypertensives to achieve optimum blood pressure targets. Also managing their diabetes, achieving better glycemic index, glycemic control, meaning that will indirectly or directly help the control of AF or their chance of being AF free. Next slide, please. So it's a class 1A recommendation. This is the latest guideline from European Society of Cardiology 2020, and class 1A indication for them to be on oral anticoagulant. Of course, the Western countries, they prefer newer agents, which are called novel oral anticoagulants. A lot of agents are there now, 4 or 5 agents. Even in Sri Lanka, one is already launched, and they are a bit expensive, but the prices are coming down, which is a good thing. The advantage of these agents over warfarin is they don't need general monitoring like INR testing like that, but warfarin need proper monitoring. But in Sri Lankan setup, warfarin is as good. Next slide, please. So I'll skip these 2 algorithms. It's available in the web if you for interested people. Next slide, please. This is managing atrial fibrillation. So the last case I like to share is, this is actually a very common problem that it's worth discussing. And this is a patient that was referred to me in Gaul, a 47-year-old female, has been thoroughly investigated over years, maybe about 6-7 years, for debilitating multiple symptoms of all types, like GORD, headache, not feeling well, lethargy, irritable, everything. She couldn't concentrate, she couldn't work, she had to stop her job, everything. So she has, by the time she was referred to us, she has had almost all the tests possible, including upper GIs, lower GIs, because she even had abdominal pains, cramps, everything. So finally, we did an ECG. Probably she had ECGs done, but none was recorded. This was the ECG. This is what we saw. She had ventricular ectopics. She had this type of ventricular ectopics. The point is, these ventricular ectopics, they can be very, very, very symptomatic. They can cause a lot of symptoms, meaning the symptoms they are hemodynamically significant. For this particular patient, she is having an effective pulse of only half of her heart rate. If we count the QRS rate here, if it is 80, actual her pulse rate is 40, because the ventricular ectopic, the ectopic beat can't produce a pulse. So there's no cardiac output for that beat. So effectively, it is like having a significant bradycardia for that patient. But if you look at the ECG, it has adequate beats. Actually, it has a tachycardia problem, not a bradycardia problem. But hemodynamically, she has a bradycardia problem. And these people actually are very symptomatic. Sometimes they are very debilitated. Occasionally, patients come because they can't walk, they come on wheelchairs. So we used to think they are benign ventricular ectopics. It's not anymore. When we do Holter monitoring, only we realize that some of them actually go into this type of things. Sustained ventricular tachycardia. So the ventricular ectopic focus is a focus that can give a sustained VT also. Even if we see isolated ectopic beats on the ECG, the focus has a potential to fire more. We don't see it. Not necessarily, not everyone will have it, but that potential is there. So if someone's history is suggestive, we have to keep a high degree of suspicion. So these are preventable or curable problems. Actually, with a radio frequency ablation, we can get rid of this ectopic focus. Patient can be completely free of the symptoms. Next slide, please. So this is how it causes non-sustained VT. This picked up on a Holter monitoring. So isolated ectopics only on the ECG, but on Holter we see this. So these are NSVTs. Next step would be a sustained VT, like that. Right. So these are the origins of various origin sites of the ventricular ectopics. Next slide, please. So in conclusion, so rhythm abnormalities or cardiac rhythm disorders are quite complex, and they are very relevant in day-to-day medical practice. And identifying them is not difficult if we keep a high degree of suspicion and stick to basics. And however much we are convinced that it's a problem, it's one problem, always make sure we stick to basics and look at other possibilities as well. And one challenge we have with rhythm abnormalities is by the time patient come to us, you might not see the problem actually. It's not like having a hernia or having abdominal lump or mass or pneumonia. We see signs on those patients. But a rhythm problem, the problem is we don't see because it comes and goes. If the patient is lucky to have it in the hospital, we fetch it. If not, they are generally paroxysmal. Either they might develop a major event or they might suddenly present with a cardiac arrest. So that's the other problem. So having a high degree of suspicion, talking to them, asking relevant questions, looking at the basic investigation are all very, very useful and rewarding. And I'm sure you will be happy picking up a problem and saving a life, and which is very easy to do when it comes to rhythm problems. Thank you very much. And I appreciate your attention. Thank you. I'm happy to answer if there are questions, but I think we took additional time.
Yeah, definitely. Questions, any please?
Yes, sir.
In your subject, you spoke of this youngster who on exertion or sports,
Yes, sir. Yeah.
sudden, say, long distance running
Yes.
and then collapsing.
Yes.
Now, it may not be a arrhythmic problem. Is it something that we can pick up for what's called the mitral valve prolapse?
Yeah.
Now, is that a condition that can produce sudden collapse on sudden exertion, which we as general practitioners should be aware of and can be picked up by a heart sound, musical sound in the heart?
It's a very relevant question, sir. I really appreciate you asking this question. This is what you're saying is very true. The mitral valve prolapse, so MVP, actually not everyone. If we look at 100 patients with MVP, they have various degrees of mitral valve pathologies, and some of them have a real risk of arrhythmic events. Very rarely they can even sustain a sudden cardiac death. But we wouldn't openly tell this because you know how often we see a MVP on the echo report. If we tell to every patient that okay, you have a risk of sudden death, I think they will not be able to live a normal life. But we tend to keep them on a beta blocker. Also, as a practice, I generally do a Holter monitoring for almost all of them, especially if they have suspicious symptoms. Sometimes it's just an incidental finding. We just pick up MVP, mitral valve prolapse, but they have absolutely no symptoms. They have very good exercise capacity. They are very low risk. But as a practice, we subject them to exercise ECG, where we test their chronotropic competence, we test their exertional capacity and see whether the rhythm can change. So I know at least a couple of cases where, including one doctor actually, who had a cardiac arrest due to MVP with mitral regurgitation. So it's a real problem. But what we know now is actually MVP is not just a localized pathology in the valve. MVP is a global pathology of the left ventricle. So left ventricle itself is abnormal, not only the mitral valve itself. So, but on the echo, we only see mitral valve prolapse and some degree of mitral regurgitation may or may not be there. But we generally don't, so many young girls or young people are there with my MVP. And even sometimes what happens is if you don't have a good echo machine, if you are doing a quick test, you might see there's maybe some degree of MVP, you might just put the label. But without doing a full assessment, if you put that label for life for that person, it's going to be a real problem. So we have to be really careful giving that diagnosis also. And the best way to avoid, if we feel they have a higher risk, the best way to prevent it is starting on a beta blocker. Beta blocker is well known to save lives by preventing sudden arrhythmias. And we don't need to give very high doses. Low to moderate dose is good enough, and a selective beta blocker is fine. So occasionally, even for people who have bronchial asthma, even we can keep them on a selective beta blocker. So that's the problem. But I appreciate you asking that question. It's a very important question. And that particular case that I discussed, actually, it was a post-mortem confirmed case of a hypertrophic cardiomyopathy. But we know there are patients who have had cardiac arrest, and the only abnormality found was MVP. So that's not.
Can HOCM be diagnosed by? How can it be diagnosed?
Yeah, so yeah, we can, sir. Even the ECG will have a lot of abnormalities. ECG will show classical characteristic left ventricular hypertrophy features with ST segment changes and T inversions. And echocardiogram, of course, a transthoracic echo, a proper echocardiogram will show myocardial hypertrophy. Sometimes it will show left ventricular outflow tract obstruction. And there are various. Now, we used to say HOCM for everything, but it's not anymore. There are so many subtypes. There are apical only HOCM, there are LV cavity HOCM, hypertrophic cardiomyopathy, and there are hypertrophic cardiomyopathy without obstruction. Likewise, there's a huge spectrum, and some of them have ongoing risk of arrhythmias, various arrhythmias.
Any other questions or suggestions? I would like to pose a small matter. You mentioned that CPR can
Yes.
save lives. I don't know how many people can do CPRs. In fact, we had a program in doctors, and a doctor collapsed there, and all were got excited about how to do the CPR. And I think as you are in the Sri Lanka Cardiology Heart Association, I think you all should go ahead and educate maybe the school children and schools.
That's very true. Actually, that type of programs are already there.
Yeah.
But what we are talking about is a massive scale, because
I
if you
know.
have to cover a population. But I really take your point, and I think that is something for a country like ours is something very feasible still. Rather than spending money on machines, having defibrillators in the community, we can easily do that. And this is something actually now, for example, in Parapity, we try to educate for people who come to my clinic. If we feel they have a high risk of cardiac arrest at home, I always get one of the relatives and we tell them, okay, in case of this, you have to do this. You only need to tell few basic things like giving proper chest compression. We don't mention about breathing because it complicates matters and it might discourage people. But if they continue to give just chest compressions, proper ones, that's enough to bring them to the hospital life, at least without major brain damage. And we make it a point to tell. So we can see people who are at higher risk. We always tell that. But if you feel someone has a very high risk, then of course we go for the next level, like implanting a defibrillator for the highest risk people.
You mentioned
Again, a very
about-
good question. Yes, yes, sir.
I had pacemaker fitted to my heart, and I was given a thing called rivaroxaban, followed nowadays after some time by apixaban. So what is the advantage of these two, which of course I had to pay a lot of money for? Is there an advantage of using these against warfarin?
Yeah, I mean, I actually mentioned about the new agents which are called novel oral anticoagulants. So there are about, now in Sri Lanka, we have 1 or 2 available at the moment, but they are pretty expensive. The main advantage we see is that you don't need regular monitoring like getting INR test done. You know what it is like having INR. But honestly, I personally believe warfarin is as good as NOACs even now. For people who, especially for people who can come to a hospital, we have INR clinics. In my clinic, there are so many patients who are on warfarin. We have not had major problems with bleeding. Never, almost never. I wouldn't say never, but it's very rare. So yeah, for people who don't like getting INR done, who find it difficult to come to the hospital frequently, and if they can afford, it's definitely a good choice. Now, back in UK, when I was in UK, I was in Manchester and Birmingham, and that was in 2013 to 2015. That was the time they have started using Novax in the general population, and people were demanding for it because the NHS, UK health system, has to provide it, because once it comes to the guideline, the people started demanding for it because they hated getting the INR test done. They don't like it there. So it has definite advantages. It's very easy to manage them. You just have to give the medication. Generally, you don't need any monitoring. And there's a problem with antidote. We don't have proper antidotes for those agents yet, but there are certain agents which we can use in place. So what you're asking is a complex question. I'm sure you would have been on warfarin before, right? Were you on warfarin before?
No, never.
Never. Oh.
No, I was put on rivaroxaban,
Okay.
amiodarone for the atrial fibrillation, and then rivaroxaban, which has been followed after some time by apixaban.
Okay. Now, what I would say is rivaroxaban and apixaban are more or less same in efficacy, and rivaroxaban in a way much easier to take because it's once a day. So now rivaroxaban, we have a local, we have a preparation which is registered just few weeks before. I can't tell the trade name because of reason, but that's much cost-wise, it's much better than the other agents. So that's a good option for people who can't tolerate warfarin in Sri Lanka. that has become. I hope there will be more agents. So it's better to have more, then the prices will come down.
Actually, you mentioned about CPR, cardiopulmonary. I think our joint secretary is Dr. Samarage is involved with St. John's Ambulance. Do you all have any program promoting that? St. John's. St. John's Ambulance.
Yeah, so we know that you have been doing it for a long time. Again, now, actually, we had a major project and discussion with Suez area to have cardiac ambulances, and actually, I was also involved with that. We were trying to get dedicated ambulances to cater for cardiac patients, at least few for each region. So that discussion is going on, and with a lot of economic problems coming up, that had to be halted. So at the same time, at the moment, Suez area, the crew can't provide that type of care. They basically transport. But I think St. John like organization can definitely look at it. It's a massive project. That's the only thing we need to understand. We are talking about every household in 20 million population, maybe. But I think it's something very useful, and that will definitely save lives. So at least the basic components of a resuscitation, I think people should be aware.
Thank you for that excellent presentation. Actually, your presentation is already recorded and it will be going on to our website. So I hope you don't mind that.
Yeah, that's
And,
fine.
we will be able to, anybody who couldn't want to use this lecture can check in on our website. And I would like to hand over a token of appreciation to
Thank you very much.
certificate to Dr. Thank you. I will now call upon our secretary to give the vote of thanks.
Mr. President, members of IMPA, distinguished ladies and gentlemen. It gives me very great pleasure this evening at the successful conclusion of this continuing medical education program of IMPA to provide the vote of thanks. The outset, on behalf of the President and the Council of IMPA, let me extend our grateful thanks to Dr. Susita Amarsingh, our resource person tonight, consultant cardiac electrophysiologist and cardiologist, teaching hospital Karapitia, for the wonderful lecture and explanations given to us. It has been a very useful presentation for our members. A very special word of thanks to our generous sponsors, USV, for sponsoring, coming forward and sponsoring this continuing medical education program of the IMPA. Very especially to Mr. Zawahir, the country manager, for sponsoring this event. Last but not least, all of you, our members and ladies invitees who have joined us this evening physically here, and also those who joined us online. Thank you very much for joining. And we have great pleasure in inviting you to the fellowship and dinner following. Thanking once our technical team also and the secretary also. And let me wish you a very pleasant evening and stay safe. Thank you.